Good afternoon, everyone. My name is Dr. Astral Webb, and I am the Director for the Health and Family Services here at North American Management. I wanted to welcome all of you to today's very important call. As an introductory call to our PLCs are together to help in your regions. So I would like to welcome all of you here today in regions 5 and 7, and this will include states of Illinois, Indiana, Michigan, New Mexico, Ohio, Wisconsin, Iowa, Kansas, Missouri, and Nebraska. So I want to welcome all of you again to today's call. We're really delighted today to not only share some information about how the partnerships between the aging networks and the health center programs are working collaboratively to meet the needs of seniors, but to also share an awareness about the idea and the opportunities that this partnership can provide in your regions. As we begin today's call, I would like to first of all recognize HRSA, who has been truly our funder for this national corporate agreement through which we can provide this training and technical assistance opportunity for our health center grantees. And again, that's in the leadership of Tiffany Smith, who is a branch chief with the Office of Special Populations at the Bureau, and also Lieutenant Commander Kevin Bates, who is our current project officer. I would also like to recognize the leadership of our ACL counterparts, Rick Nichols, Greg Case, and Michelle Washko, who have been working with us collaboratively in order to make sure that these collaborations are successful. I would also like to recognize as participating in today's discussion would be on the call today would be Lance Robertson, who is the state director for your region in Oklahoma City, and who is also the president of the National Association of States United for Aging and Disabilities. So we're really delighted to have the leadership of all these individuals and so many others who have worked with us. You will also later on hear from one of our collaborative partners at the national level, namely the National Council on Aging. So we would like to thank them for their availability, for being here and taking the time out for today's discussion. So let me give you a brief few remarks about North American Management and a little more information about the National Corporate Agreement. The National Center for Health and the Aging is a project of North American Management and is supported in part by this National Corporate Agreement awarded to North American Management by HRSA in September 2011. The National Center for Health and the Aging provides training and technical assistance to strengthen the capacity of federally funded health centers to increase access to quality health care, eliminate health disparities, and enhance the health care delivery for the 39 million or 13% of Americans who are age 65 and older. Because of the elderly's unique and various needs, targeted outreach is very critical to providing assistance to access of health services, which is greatly necessary. And in order to increase the capacity and improve the performance of these HRSA-supported health center programs across the country in meeting the specialized needs of seniors, we here at the National Center for Health and the Aging have developed many materials, training and educational materials, disseminated best practices, and we mentor especially our new grantees who are new to senior health outreach. It is important to us, not only through this corporate agreement, to provide that training and technical assistance to strengthen these health centers and support their work and their needs, but also without the collaborations from many of our national and state aging agencies, we would not have been able to do the work that we have to do. So we want to thank them. And we also want to let you know that we will host our annual Aging Symposium sometime in April 2013 in the Washington, D.C. area. This is an opportunity to bring together not all of our aging networks and health center programs who are working currently to provide the health needs of seniors, and it's an opportunity for our health centers to network with their aging counterparts who really help address not only clinical but also the non-clinical needs for the health centers. So at North American Management here through the National Center for Health and the Aging, we provide remote as well as on-site and one-on-one training and peer mentoring for the HRSA grantees. On today's call, our objective is to unite the aging networks as well as the primary care and preventive care providers so that they can strengthen the work that they're doing. We also try to develop protocols and tools that are necessary. We bring together through our collaborative partnerships numerous resources that are available to our health centers as they continue to do their work. Knowing that many of our health centers serve a huge underserved populations, some of them are from the special populations, the public housing, migrant, and homeless populations. But in addition to that, there are many seniors who lived in disadvantaged communities that our health centers can be a form of support, especially in your region. We also like to share a lot of information about health literacy and the skills necessary to work with the seniors in these populations so that they truly can empower them to take better care of themselves as well. So outreach to seniors and connecting the resources necessary to provide that medical home and medical home model support for the seniors is one of our primary missions here at the National Center. So we provide a lot of our resources through our website where we do a number of webinars, provide fact sheets, monographs, many of which we do with our aging network partners, and we really highlight some of the key issues going on in the senior care issues, really share strategies that have worked in terms of outreach and enrollment to seniors, and providing you as health center grantees the opportunity to truly provide a medical home model for your seniors. We do know there are many barriers. We know there are many challenges, and through these partnerships with the aging networks, we hope that many of these can be addressed. We have already seen it work in many communities, but we have, HRSA has over 4,000 health centers, community clinics, and who provide care to those in the general population. And so we do know that there's so much more room and growth and potential. But I do want to share some things that we have done this past year, including the webinars, the monographs, the fact sheets. They are available on our website at www.healthandtheaging.org, all one word. And I really encourage you to visit our website. You can find links not only to the health centers but also to the aging networks or the resources that have been shared with us for the health centers themselves. In addition to that, at the end of this, feel free to join our mailing list. You will get more information about the symposium and about many of the other work plan activities that we have scheduled to support our grantees. I would like now to switch a little bit gears and tell you about some of the things that are happening in your regions 5 and 7. Again, all of the states that are participating, these are cumulative numbers, and we do know that according to the UDS data, the total number of patients being served in your region right now are somewhere about 3 1,660,000 patients who are being seen. There are a total number of 202 health center programs that provide care to these patients in your region. And in your region in general, the total number of seniors is about 203,687 individuals. So what we see is there's truly a large unmet number of needs, and through the collaboration between the aging networks and the health center programs, we really believe that we can bridge a lot of the gap. There's still a lot of work to do, and it will not be done in a very short period of time. But as our health centers are beginning to see the growing number of aging boomers, it's really important to really think of how are we going to address the healthcare issues of these populations. I do want to highlight that the health center programs in Illinois have the highest number of total patients served right now in your region. They have the most number of seniors that they actually see, and the highest number of health center programs that are currently seeing those vulnerable seniors. Michigan health centers serve the second total number of patients as well as the number of seniors in regions 5 and 7. So we just wanted to address some of that, which is one of the reasons that we were able to invite one of our speakers from the Illinois region to highlight some of the work that they are doing. So before we get to that presentation, I do want to share some of the challenges and barriers that our health centers face. Many of these health centers see a huge number of uninsured patients. And when they're looking at their senior populations, in most cases, over 50% of the patients are uninsured. So our health centers have had to try and figure out how best they can see these patients, knowing that in some states, Medicaid does not really reimburse them for many of the services they can provide to this uninsured population. So despite that challenge, the health centers do try to provide as much in terms of care that they can. Their objectives are to provide that medical home, and as we know, HRSA's goals for them is to make sure that it can provide not only access, but to provide that quality care, they must have a medical home model in place. So several health centers have already begun that process. There is still some way to go in that area, but in terms of providing services for seniors, many, if not all the health centers provide some form of primary and preventive care, and for seniors, services such as podiatry, psychiatry, where they see a lot of depression and isolation, especially by these seniors who live alone. They see a lot of polypharmacy, where many of the seniors are on multiple medications, and there are side effects. Most of the seniors seen in these vulnerable low-income areas tend to have multiple chronic diseases. So you're dealing with diabetes, hypertension, obesity, cardiovascular disease. They have the arthritis on top of everything else. So, and many others that we haven't even named. But they have to make sure that their patients are on the adequate medication. So many of them are part of the 340B program, pharmacy program, so that they can provide on-site pharmacy needs, a one-stop shop kind of model to provide the medication for their patients. In addition to that, even their treatment plan, it's really important for them to have a sound treatment plan that will work in the benefit of that senior patient. A lot of one of the greatest needs for these health centers serving seniors is specialty care, and many of them have not been able to truly have all of them collectively in-house. There are many health centers who have moved towards that, but there is always a great need to have not only the pharmacist there, but a podiatrist, case management for the seniors, and so forth. And so in working with the agent networks, what we did recognize is there's a phenomenal opportunity for these health centers to be able to provide some of those services if they have not already been able to fund it. Many of these programs are funded through some support from HRSA, through other funding opportunities and grants. There are a number of opportunities out there, but the health centers must be able to sustain that model as they continue to increase the number of new patient encounters that they see every month. And with the aging boomers coming out, we do know that they are seeing a tremendous number of patients. In the low-income areas, there's also always this issue of trust. These providers, these health centers who work feverishly must develop that trust with these patients. Many seniors have, for many, many years, they've had a certain provider, and now that they may have no insurance, or because of the models, or because they've had to retire out into lower income areas for whatever the reason is, or the aging grandparents who are now coming out, they have had to depend a lot on these community health centers that are there. But it's not always so easy for that health center without that trust. And so we recognize that even looking at the workforce in these health centers, not only do you have to have these patient navigators or the community health workers out there advocating for them, but they also have to be culturally competent, culturally sensitive. They have to be able to speak the languages of many of the seniors. As we are seeing right now, there is a growing number of non-English speaking populations. Many of our health centers, a lot of them, they have up to 8 spoken languages a day. There's some of them all the way up to 31, 33 spoken languages a day. And so that gives you an idea of what some of the dynamics are in terms of workforce issues with health centers. We did learn that on our Aging Network side, and you're going to hear a little more about that from NCOA, there are numerous opportunities for partnerships on some of those levels. So we really want to embrace some of them. And again, for many of the seniors for these health centers, one of the big barriers is transportation. The seniors, especially those who have multiple chronic diseases, they want to age at home. There is that, how do we get transportation and get them to the health centers to receive the kind of care that they need? There's a great need for home services. We know many of the aging networks are already seeing that, especially as seniors are discharged through the hospitals and they're going back into their home environment. They provide that case management, but the health center programs also stand to be part of that partnership, to be an opportunity for you to refer them to these health centers for follow-up care. It is a lot less cost-effective for the entire region and for each state, for even on the hospital side. And so some health centers are trying to actually work as well with the hospitals in the areas and talk about potential ways of sustaining the opportunities to provide access, not only access but also quality care for their residents, their patients. So we really want to see some of that materialize, especially in the new partnerships that will be formed. And again, behavioral health issues, very big concern, especially for senior populations. The chronic diseases, as you know, are very pervasive. If these seniors do not have family members and family support, it's very, very difficult to get them out to the sites to get the care that they need. And then many of the health centers use mobile vans. Sometimes they're out in the communities 2-3 times, some of them daily, 5 days a week, providing the additional services. Some of them, they can provide the specialty services that are needed. They can provide oral health access. They can provide x-rays if that's necessary. So there are many comprehensive type services that can be provided through the addition of the mobile vans. And we do know in your communities, in your states where you are, there's always this tremendous need for rural health outreach. And these are some of the ways that our health centers are really utilizing in order to reach the seniors in those populations. So I am going to take a brief pause, and I would like to introduce first of all, the National Council on Aging. Ms. Mary Walsh will represent them. This is truly one of our collaborative partners, and we were going to get a more general overview of some of the services and programs that our aging networks can provide. And then following that, we will hear from one of our health center partners that has worked with our health centers in order to provide some of the care. So Mary, I will now turn it over to you. Thank you for joining us today.
Thank you, Astral, for giving us this opportunity. As Astral said, I'm Mary Walsh. I'm a Senior Program Manager at the National Council on Aging, which is a private nonprofit service and advocacy organization based out of Washington, D.C. The mission of NCOA is to improve the lives of millions of older adults, especially those who are disadvantaged and vulnerable. Through the National Council on Aging, there is a Center for Healthy Aging, which is where I work. And the Center for Healthy Aging provides technical assistance to evidence-based programs, and we are funded through the Administration for Community Living and the Administration on Aging. The Center for Healthy Aging has the goal of improving the health and reducing disability among older Americans. In order to do this, we work with a number of organizations at all different levels. We work with some of the federal agencies, we work with states, we work with local community organizations. One of the things we do is identify, translate, and disseminate evidence on programs that have proven to work. We also promote community organizations as essential agents who can make change in the community happen and make change for older adults happen. We reach out and include diverse older adults, and we also advocate for support for strong and effective community programs. I'd like to just take a few minutes to talk about the aging of adults in America, and I'll take just a few minutes because we all know that there is a huge group of baby boomers who are moving into the older American situation. The first wave of baby boomers reached retirement age in 2011. And over the next 20 years, there'll be 74 million boomers who will retire. The result of that is that every day, at least 10,000 new retirees will be added to Social Security and Medicare. So we're coming. Those baby boomers right now represent what's called the young old, those who are just who are age 65 to 75. Beyond that, there are those who are considered old, which are 74 to 84. And those numbers are increasing also as people increase their life expectancy and lead healthier lifestyles. The biggest change in aging is among the oldest old, which is those who are 85 and older. The fastest growing segment of the total population is those who are 80 years old and over. Their growth rate is twice that of those who are 65 and older, and almost 4 times that for the total population in the United States. That group is now 10% of the older population and will triple from more than 5.7 million in 2010 to over 19 million in 2050. One of the agencies that we work with very frequently is the Administration for Community Living and the Administration on Aging. The Administration on Aging was recently consolidated under the umbrella organization of the Administration for Community Living, along with the Office on Disability and the Administration on Developmental Disabilities. The role of the Administration on Aging is to help older adults maintain their health and independence in their community. And now that role is expanded to include individuals with disabilities. The Administration on Aging began in 1965 when the Older Americans Act was passed. And the act was passed because there was a concern about the lack of community social services for older people. So the Older Americans Act established the Administration on Aging, and that administration has the authority for grants to states around community planning and social services, research and development projects, and training in the field of aging. Although older individuals receive services from a number of different federal agencies, the Older Americans Act is considered to be the major vehicle for the organization. And it delivers programs that you have, I'm sure, heard of before, programs like Meals on Wheels and Congregate Meals, information and assistance, family caregiver support, senior employment, and a number of others. One of the newer programs at the Administration on Aging is the Aging and Disability Resource Centers, which are now available in almost all, if not all, of the states. The ADRCs, as they're called, are a one-stop, provides one-stop access to services and information for older adults, for people with disabilities, for their caregivers, and for family members. So it's a place that a person can call and get the information that they need. They can get information about things like Alzheimer's and caregiver support, care transitions, community options, veteran services, meals and rides, benefits counseling, like for Medicare benefits or Part D, and also information about evidence-based programs like chronic disease self-management, matter of balance, and others. Evidence-based programs are programs that are proven to deliver health benefits to participants, and they can also change the systems for older adults so that they become activated self-managers. The Administration on Aging has, over the years, had several funding opportunities to states so that they can begin and build and enhance evidence-based programs. And one of the programs I'm going to talk about right now is the Chronic Disease Self-Management Program. In 2010, the Administration on Aging, through Recovery Act funding, funded 45 states, Puerto Rico, and the District of Columbia to begin or to expand their evidence-based programs, especially their chronic disease self-management. And over the course of that grant, over 75,000 completers went through chronic disease self-management, and there were over 100,000 participants in the program. That grant not only brought to scale some of the evidence-based activities, but it also enhanced the sustainability, and it improved efficiency, quality, and cost for chronic disease self-management. Just this past September, the Administration on Aging had a new funding opportunity, and 22 states were awarded funds to help ensure that chronic disease self-management education programs are embedded into the health and long-term care services and support systems. States under this grant are charged with significantly increasing the number of older and disabled adults who have chronic conditions who complete chronic disease self-management education to maintain and to improve their health status, and also to expand and strengthen integrated and sustainable service systems. The role of the NCOA, the Technical Assistance Resource Center, in all this is to provide rapid, targeted assistance to grantees, to provide technical assistance that is targeted at performance improvement and knowledge of best practices, to document and report nationwide participation and capacity, and to conduct a national study to document the individual outcomes associated with participating in those chronic disease self-management programs. In order to do this, the Center for Healthy Aging at NCOA works with a number of different partners. On the federal level, we work very closely with the Administration on Aging, with the Center for Disease Control, with HRSA, with Substance Abuse and Mental Health Services Administration, and with Center for Medicare and Medicaid Services. At the state level, we're working with the state units on aging, the state public health departments, and the state Medicaid offices. And on the local level, we're working with over 6,000 host and implementation sites, which include area agencies on aging, healthcare systems, senior centers, senior housing, faith-based organizations, multicultural organizations, and many others. To give you an example of some of the programs that are funded, some of the evidence-based programs that are funded by the Administration on Aging, I'd like to just share a little information about a few of them because there are over 30 programs that are recognized by the Administration on Aging. In terms of physical activity, there is an arthritis exercise program, There is a Walk with Ease program to get people more active. For self-management, we have not only the chronic disease self-management program, but also the diabetes self-management program and self-management programs for chronic pain, HIV, as well as online programs. For caregivers, there's a community stress busting program for caregivers. There's an Alzheimer's caregivers health program and some other programs for caregivers. Around depression management and behavioral issues, there are Healthy Ideas and Pearls, which help older adults with depression. There also is a program for the prevention and management of alcohol problems in older adults. For fall risk reduction, we have A Matter of Balance, Tai Chi, and Stepping On. And there is also a program for medication management. I know many of you are involved with the patient-centered medical homes and for recognition as patient-centered medical homes. And there are some strong ways that chronic disease self-management can tie into that endeavor. The critical role of patient self-management and practice self-management support is one that can include chronic disease self-management, because there's a need to document self-management capacities, document self-management goals, provide tools and resources, counsel older adults on healthy behaviors, and assess, provide, and arrange for mental health and substance abuse treatment, as well as providing community resources. CDSMP can be a key component of several of the patient-centered medical home standards, in particular the standard number 3, which is around planning and managing care, and standard number 4, which is to provide self-care support and community resources. In addition to the chronic disease self-management, the National Council on Aging is very involved with diabetes self-management and is working with area agencies on the local level who are partnering with federally qualified health centers to get the diabetes self-management program accredited by the American Diabetes Association and the American Association of Diabetes Educators. And in 2 areas, the accreditation has been achieved, and there are a number of states that are also looking to getting the accreditation. Many of you, I'm sure, have older patients who come in after suffering a fall. It's a very frequent occurrence. And there is a Falls-Free initiative, and 46 states are involved with that initiative. And it works with evidence-based programs that help older adults recognize their fear of falling and help themselves prevent falls. At the National Council on Aging, we have a number of online tools for building systems around evidence-based programs. And on our website, which is www.ncoa.org, you can find information about best practices around evidence-based programs, replication reports, online training manuals, webinars, sustainability ideas. And you can also see the data collection system. And in addition, there's also an online learning community. So I've gone through a lot of information in a very short period of time, but there are a number of resources on the NCOA site, and I'd urge you to take a look at it. And the slides for this presentation are also going to be available through Asterisk. So you can take a look at that, and a number of these websites will be found there. So thank you for your attention, and please let me know if there are any questions I can answer for you.
Thank you very much, Mary, for that presentation. And like Mary said, we will have all of the information on today's presentation available on our website at www.healthandtheaging.org, all one word. We will also have an archived version of this telephone call today that will be made available for those of your colleagues or, who were not able to participate on today's calls directly. I would like to introduce our next presenter, who will actually just give you a little bit of an overview of some of the work that they are doing in Illinois. John Becker is the Executive Director of Senior Services Plus in Illinois, and he works very closely with one of the health center grantees at Southern Illinois Foundation. John, if you can, I would like to actually turn it over for you just to speak for a few minutes about your partnership with the Southern Illinois Foundation Hospital.
I work for Senior Services Plus in Alton, Illinois, and just a little background. Our agency is located in Madison and St. Clair County, which are the two largest counties outside of Chicago and Illinois, and they're considered part of the St. Louis metro area. Our agency is a large senior service provider. We serve over 30,000 folks a year. We do Meals on Wheels. We do a lot of partnerships with the area agency in our region, and that's information and assistance, limited transportation, congregate meal sites, and we also have a very large community care program or in-home non-medical homemaker type program that we contract with the state of Illinois for. And probably about 3 years ago, when we started seeing the coming of managed care in the state of Illinois for dual eligible individuals who are receiving Medicaid and Medicare, it was actually implemented in 2012. We realized that for that reason and many others, we had to start to seek out a partnership with and I just think of it as a medical group, a non-for-profit that really kind of shared our core values and our mission. Like many senior centers or social service agencies that serve seniors, we get a lot of requests from for-profits to come in and provide services, home health, elder abuse, our elder law attorneys, people that are coming in to get access to our referral base, which is large. And we're very selective about who we partner with. Southern Illinois Health Foundation was somebody we approached 2 years ago because they are a extremely large provider of services in clinics. They operate pharmacies and are local mental health providers. They have the same values in terms of the people they're trying to serve, low income, of which that includes elderly or seniors. So it was a very natural partnership for our agency. Although we have a large non-skilled medical, we do not provide home health, and we're not or in the foreseeable future, going to start up any kind of skilled medical services. So finding a FQAC that mirrors what our mission values are was very important, and the Southern Illinois Health Foundation has been a tremendous partnership for us. It's initially started with us having a home health provider that we could essentially trust to work with our seniors that we're doing non-skilled medical for. So we started with a referral base back and forth with them, and it evolved into quite a few things, actually. They rent an office in our facility, and at our main facility in Alton, we have a fully outfitted wellness program, which is commercial-grade gym equipment, exercise classes, and we offer it based on our mission, which is to provide affordable wellness for people in the community. So it's $100 a year. Having a medical provider in the building with us, they provide a nurse that does blood pressure checks. They also come in and do a lot of the ancillary services that seniors are looking for, the flu shots, pneumonia, balance prevention, our balance screening, fall prevention, that kind of thing. It really started small and started to build from there, because in turn they operate 32 clinics in 2 counties. We started a trade and office space to have our homemaker staff in a urgent care facility of theirs, and they operate a hospital and a large senior living complex. We have staff there for homemaker services, but we're also going to start doing community-based exercise classes for their senior population. So the partnership for us has been really good, because we don't provide those medical services, nor are we going to. That's not within our capability. Having a partner that has provides quality services and has a good name coming in and providing those services, which for the managed care that's coming in Illinois, is very important to us. It's not only been beneficial for our seniors, they also provide services, like many providers, for many of our staff. And we have over 300 employees, of which many are single moms that have Medicaid or Illinois health insurance cards that receive services through the Health Foundation. So it wasn't just our client population of seniors. Many of our staff were eligible for some grant-funded activities that the Health Foundation does. In addition to the partnership that we've developed, what I didn't realize before I started working with the Health Foundation, a very low percentage of their client base were seniors, 7 to 8%, and a lot of that had to do primarily with the fact that the senior population go to their primary care physician and they stay with them for a long time. What we're trying to change, and have started to change with that, is to expose seniors who are low income or at a poverty level to medical options that they may have not known about before. Because one thing about our specific area, Madison County, and I'm not sure that a lot of people know about it, in 2008, we were considered one of the worst counties for doctors to do business in, because of the legal system we have, and we had a lot of physicians leave the area. That has reversed itself, but there was a real need for seniors to find primary care physicians, and from 2010 until now, the Health Foundation has been a big part of that. The information that we trade back and forth, we have a very active information and assistance program funded by area agency. A lot of the services that we talk about now, as far as assisted living or affordable housing or primary care physicians or other things, we refer directly to the Southern Illinois Health Foundation. And they get, like probably many of the medical providers, they get grant opportunities that we can't apply for. And that has developed into a whole nother partnership of grant writing. We provide wellness services here at the facility, but at 3 different locations at senior housing. And our expertise in the wellness area, combined with their background for medical services, has allowed us to start brainstorming and looking at applying for large regional grants to access or provide more access for seniors for wellness. It's been a great partnership, and quite honestly, when we first started discussing it, our biggest issue came up was to develop a partnership proposal that help avoided any violation of the Stark laws. And their attorney and our attorney were able to craft that and put it in place. And, that was just one of those check-off list things that you had to do. And once we got past that, there are so many things we're doing together now. It's a great relationship. And I see a lot of possibilities for us and them down the road.
Thank you so much, John, for those words. I think just the lessons learned that through these partnerships between the health center programs and the aging networks, they truly, really work and make a difference in those communities. So I cannot say it enough that how important this kind of collaboration that started with HRSA and ACL at the federal level has made such a great difference. And as we've seen these the relationships actually at the local level, we really, really understand how we better can work together. So, John, thank you so much for sharing that. And in the meantime, what I will like to share with you is what some of the health centers are doing with some of our aging networks. We know that that right now there are very few health center programs. Health centers that are currently actively working with our aging networks. So we know that potentially there is a phenomenal opportunity to have a lot more of those partnerships. And what is interesting is that all of the health center programs that have implemented such a partnership have really been able to not only meet those clinical needs, but also the non-clinical needs and the ancillary services, support services that are necessary. Case management is one of those issues, and that's really highlighted. And as Mary mentioned to you as well, what we're seeing is that because the health centers are being able to use a lot of those resources through the aging networks, they're better able to document even through their EHRs on a lot of the requirements in order to become that patient-centered medical home. So I really want to encourage especially our health centers, the PCA partners who are on the line today, to have the health centers really look at some of those tools and resources. It has been making a tremendous, phenomenal difference in many of those health centers and in the communities that they are serving. In addition to that, we really want to let you know that we have covered many of those topics as well as webinars, which can be found on our website. We have done webinars on how to actually help health centers get reimbursed as well for some of the services they're offering. And I believe, Mary, that NCOA is actually doing with a webinar with us actually in spring where they can talk about a little further on that. So please keep that webinar in mind as well, because it's a great opportunity, depending on what we hear is coming down the pipe at the end of the new year, for many of the health centers to really think of how they can make senior health care reimbursement changes to what's making that model more sustainable, and so that they can really see the growing number of patients. And I believe that the chronic disease self-management program, the diabetes program, and all of the other programs that Mary alluded to earlier, many of them are already being implemented in many of the health centers. And the health centers are reporting that for those that have adopted the chronic disease self-management program, it has been such a great benefit to their patients. Not only most of the health centers, patients spend only about 3% of their time working directly with care providers. That 97% of the time, they're kind of on their own to try and figure out how to comply with the medications, how to do all the things that their doctors told them to do. And doctors, nurses, the case managers, whoever, whatever health professional they're working with. So we do know that through these self-empowerment type programs for the grantees, for the patients, it really empowers the seniors to take better care of themselves. And what we know in the populations that our health centers are serving, sometimes it's just the lack of education of what diabetes does mean, what does heart disease mean. And so for many of the populations, they have, a lot of patients have accepted the fact that this is run through my family and it is supposed to happen. But the reality is that we know, even through health education, that even changing that knowledge base, that this is not normal, that there are things that you can do, just small changes. So we see a lot of our health centers have implemented or helped implemented, whether they're partnering with community-based or faith-based organizations. They have walking groups. They have gardening groups as well for seniors. Not only is it therapeutic for them, but it also helps them spend a lot of the time that we see that they have in isolation. So we know that really to address the true improved health outcomes, we must address the social determinants of health. And through the partnerships with the aging networks, many of our providers on the health center side have been able to and can potentially improve those, improve the social determinants of health. So in our special populations that we see in the housing, public housing, in homeless, and in the migrant populations, there is this great need to really try and bridge some of those services, because it's the only then when you have all of these, or you try to meet as many non-clinical and social needs, that you really see improved health outcomes. And that partnership between aging networks and the health center programs is really critical in really changing and addressing the future of senior health across your region. In many of the states, like I said, especially in Illinois and Michigan, where we're seeing there are already partnerships, there's a great number of seniors being seen. We do know there's still a lot of needs. There's still a lot of opportunities for the partnerships. So we do welcome them. We have also noticed that with the growing number of, when we look at men and then women health issues across the country, one of the areas that we're looking at is that senior population. Many seniors, they are sexually active. They are not being screened for many of their services, and we're really encouraging many of our health centers through our National Corporate Agreement partnership to try and utilize some of those resources that are available to help them better screen. HIV/AIDS is a very big issue, especially with the senior population, and as the aging boomers are growing out, what we're seeing is a large number of HIV cases as well. So that's one of the areas that we would like to connect with. We do know that there are many programs available in the states to provide areas like food for them and support them with housing issues, etc. So this is one of the great needs that we're seeing on the community health center side. Even if they have a HIV positive patient, they have to be able to find them and link them to social services. So as much as there are a lot of other issues, we know breast cancer, mammograms, prostate screening, a lot of our health centers are actually providing in the senior communities, even for seniors in general. It's a very important, very preventive form of screening. Early detection is key, and there are many, many preventive activities that a senior can take on. Like Mary alluded to earlier, falls. It's the number one problem that we see among seniors. NCOA has really been able to help us connect many of our health center grantees in their very states to get trained on just things that they should know in terms of screening questions that they ask seniors. For many reasons that seniors fall from things as changing the lights to dim, and they fall to they have too many steps that they have to climb when they have to move to not having the glasses where they can see properly. And many of our health centers, through the consultation that they do, whether it's through telehealth, telemedicine, many of the health centers are designed to provide those kind of additional services, like with ophthalmology. They have an optometrist they can actually refer their patients to, and the same thing with those that need hearing aids. So there are many needs with the senior populations, and we do know that our health centers are doing tremendous innovative things to really reach out there and try and address some of those needs. But again, I think there's a phenomenal opportunity as they're working with the aging networks to really bridge a lot of those gaps. And it's also a win for the aging networks as well, because as we alluded to before, these health centers are designed to be medical home models, and they can provide that medical home model for seniors, especially those who have no primary care provider. And so we would encourage all of what we would hope to see by next year is that every health center program, federally funded, federally qualified health center or look-alike, is connected with some form of an aging network, and vice versa. And Mary, we know there are limited numbers of programs that I think you mentioned in 22 states where they do have funded programs that can aid as well. And so for those states that do have them, we really encourage you to utilize those opportunities as well, because it can make a tremendous amount of difference to your population. HRSA has not only made sure that their health centers are moving towards medical home recognition, but they're also implementing EHRs and adopting them so that they can have the information in real time and really better help your senior patients. We are working feverishly to try and make sure that we can address some of the reimbursement models. Right now, most of the health centers are not getting full reimbursement for providing services to senior care, which is one of the reasons many health centers have not provided it in the past. But now that they know that there are these partnerships with the aging networks, especially for those who have a large number of seniors, they know, they can utilize some of the resources they're learning about and adopting them. And I know some of those health centers are on the line right now, and some of the primary care association partners who can help with that. So we look forward to working with all of you to bridge that gap. So whether you're an aging network, whether you're a health center program, whether you're federal, at the federal, state, national, local level, we are going to embrace those partnerships. I do want to remind everyone about our national conference again in April 2013. We know many of you are coming from the aging side. You're coming probably to attend one of the conference, the Symposium by the National Council on Aging and the National Center for Health and the Aging. We will have our conference very near to that one, where it creates an opportunity at our symposium not only to provide workshops for you to learn how to really improve the health care of your seniors in your communities, but also for that networking opportunity between the aging networks and the health centers. We encourage you to, again, look out on our website for more information on that. As we get closer to that date, there is a call for abstracts that is currently out and available. So if you, and especially in your regions 5 and 7, we would love very much to hear about some of the work that you're doing and some of the training that may be available for some of our health centers to really help them maximize on the experience, get up quicker running to really address senior health issues. And as Mary alluded to earlier, we cannot wait because we have an aging, booming generation coming out, and we have to make sure that all of our healthcare providers are ready to meet the needs. Some of our health centers do not have geriatric specialists on their team, and so we are working really closely to make sure that they're connected somehow to some kind of a senior program or senior service network as well. And so I think this is truly an enormous partnership and a great collaboration. I want to thank HRSA and ACL again for coming together as two HHS agencies, understanding there is this need and understanding that there is such an opportunity for the grantees to be working closer together so we could really bridge some of these gaps, provide medical homes for every senior in this country, and really do that as a cost-effective way, provide the access, provide quality care, and be able to connect services in ways that we have not in the past. I do want to thank our speakers today. I'm sorry that we could not get our partner here in Illinois to connect with us, that we were having a couple of technical difficulties on our lines, but we do know that many of their best practices that work in your region will be highlighted at another time on a later webinar. So we actually ask you to tune into our calendar of events so that you are aware of that. Again, Mary Walsh, thank you so much for representing all of the aging networks, sharing with us what ACL, AOA, NCOA, and all of the area agencies on aging, what they're doing and the work that they're doing. And again, I want to thank all of our partners who have worked with us, especially over the last 2 years, to really shape, what healthcare can look for in the future, and especially working with community health centers. So we really want to encourage all of you, stay connected to your agencies. There are some changes that are coming through, as we know, under the Affordable Care Act. There are many things that will benefit seniors, and we're going to look forward to those opportunities as well. And if you have any questions, if you need to contact me for any reason, feel free to contact me. My telephone number is 703-812-8822. And my email address is awebb, it's spelled AWEBB, @NAMGT.com. So feel free to contact me by email or by phone. My staff is very much ready and available to share resources with you as well. And all of the resources that Mary shared with you earlier on will be as well on our website, especially for you who are health centers and the Primary Care Association partners. Without your support, we could not do some of the work that we do. So we really want to embrace that. Thank you all again for taking the time out to join us on today's call. And we hope that we have provided tremendous information for you. And if you have not yet connected with your local FQHC or health center program or your local aging network, please feel free to contact us as well if we can facilitate the process in any way. So, Mary, thank you again for your time. Thank you, everyone, for joining today's call. And the webinar will be archived, and we will be able to send it out to you all by the close of business today. Thank you, everyone, for joining today's call.